François told me to say.
So, welcome to the Euro Intervention on Air. My name is Julia Grabsa. I'm live from Brigham and Women's Hospital in Boston, and it's a great honor to have Professor Jean-Claude Deharot with us. And we are going to discuss an important document. Professor Deharot is co-chairing this document together with Professor Fabien Praz, and Professor Deharot is representing ERA and Professor Praz EAPCI. And it is management of patients with transvalvular right ventricular leads undergoing transcatheter tricuspid valve interventions. And this scientific statement was also endorsed by ESCHRS, Asian and Canadian Heart Rhythm Societies. And I would prompt you to read it. And also, during this 15 minutes, this conversation, please submit your comments or questions for Professor Deharot. I will start by an introduction. Professor Deharot is a professor of cardiology at Marseille Medical School, and he's the head of arrhythmia department at La Timone University Hospital of Marseille. And he is world lead in cardiac pacing and lead extraction, participating in several ESC and ERA guidelines and consensus documents. Professor Deharot, Jean-Claude, it's a great honor to be here with you. And I will start with the first question that we see extensively being discussed, the modern problem of tricuspid regurgitation. And from your clinical experience, the population of patients with devices and tricuspid regurgitations has increased.
Yes, hello to everybody. Hello, Julia. Thank you for the question. Yes, it is true that for many years we really ignored this issue. And we ignored this issue mainly because we did not have any other solution than implanting leads across the tricuspid valve. But we know, and this is now really known, that about 25% of the patients with CIEDs crossing and leads crossing the tricuspid valve will have some tricuspid valve regurgitation aggravation. I mean that probably they will have tricuspid valve regurgitation on baseline, but it will be aggravated by the leads. And why does it occur? First of all, we are aware of the issue and we look for this regurgitation more closely. I think this is something that we probably are doing every day in our practice. Second, our patients are more and more sick. Many of them have heart failure, very dilated cavities of the heart. So this may explain also the tricuspid regurgitation. And finally, and I think it's also something that we have to consider is that many of our patients are receiving many leads crossing the tricuspid valve. And this has been shown as a factor for tricuspid regurgitation. So this is something which is true. I really believe that many of our patients do have this kind of tricuspid regurgitation. And in the statement that we wrote, which was just a scientific statement, meaning that it just collected scientific evidence and it does not give any recommendation. In this statement, we mentioned that probably it might be interesting in the future to perform at baseline an echo study before implanting a lead through the tricuspid valve, and this is recommended by the guidelines. But also to redo this kind of study after, let's say, some weeks. We wrote something like 6 weeks because we find very important to know what really occurs early after the implantation in order to be able to follow up the patient for long time and know what occurs a long time. So so this kind of study for us is important. So yes, it's an important issue and we should be aware of it in our clinical practice.
It's amazing. Thank you so much. And it brings me to mind that, the tertiary center is ideal for these patients because they have what we call the multidisciplinary heart team. And I want your opinion about how important are the meetings of the MDT meetings that we take a decision for the patient all across the specialties with an imager, electrophysiologist, a surgeon, and the structural interventionist. What's your opinion about these MDTs?
Yes, you are really touching a crucial point. For all these patients, and this is one of the conclusions of the paper, we do not have a lot of evidence to take decisions. We do not have guidelines. We do not have evidence to really guide our colleagues. So for every patient, we have to take a single decision, and this decision is coming from a meeting of the specialist you were listing. I mean, of course, the surgeon, of course, the interventionist who will be involved in the decision of performing tricuspid repair and which kind of tricuspid repair. And imagers and EP doctors are also very important because they will give their contribution on the potential risk of removing a lead or leaving the lead in place. Also on the potential role of the lead in tricuspid regurgitation. So really, this discussion is something which is very, very important. And also, what we wanted to emphasize in the document is that apart from the discussion between specialists, also there will be a discussion with the patient because these patients are somehow very frail. I mean, the ones who are contraindicated to surgery, they are frails. There are many comorbidities. And it might be that we will take a decision taking into account their frailty. Yeah, ideally, it might be interesting to remove a lead before implanting a valve. But in some patients, we will not take this decision, and this will be shared with the patient and also with the caregivers of the patient. They also should be aware that we did something with the leads and with the tricuspid valve, and that in the future, both should be followed up. I mean, the device, but also the tricuspid valve and the repair. So this is really a key discussion that we will have, including specialists on one side, but also including patients and caregivers.
Thank you so much. Another important part of the document that it's very unique when compared to previous statements is for the first time you discuss tricuspid valve replacement and several techniques around the leads. What is your opinion and your experience with lead jailing?
Well, this is also an important issue, and this is the reason why we had the idea of writing this paper. And you mentioned that it is a joint initiative between electrophysiologists, ERA, and interventionist, EAPCI. And the reason why we decided to do this is that we really wanted to emphasize that there was some potential risk in jailing a lead. Jailing a lead means that the lead will be jailed between the device, which has been used for the tricuspid regurgitation repair, transcatheter tricuspid regurgitation repair, and the heart of the patient. And this has potential implications. First of all, if you jail a lead, you will have a mechanical stress on the lead. And you know that we don't want lead to be stressed because when a patient is pacemaker dependent or a patient is ICD dependent, it might be that the lead may break a long time due to this kind of tensions, of mechanical tension. And this, of course, is a major issue. So this is the first and important thing that we wanted to emphasize. Secondly, the quality of the repair, the transcatheter repair of the tricuspid valve might be impaired by the lead. For example, if you want to deploy a lead and if you want to deploy a valve, and you have one or two leads jailed, maybe the deployment will not be optimal. And then there will be like a residual regurgitation, which might be, of course, something that we would like to avoid. And thirdly, and this is very important for us, thirdly, in case a patient has an infection of a lead, which is something which is not completely unusual. And I mean, this can occur, and mainly in frail patients like the ones we are talking about today. In case a patient has an infection of the lead, it will be quite impossible to remove a jailed lead. And this is something that really has to be taken into consideration before jailing a lead. This is why the discussion between the specialists is so important. Sometimes we will take all these risks, but this is something that we will have to really discuss and balance before taking a decision. Because when we jail a lead, this is something which is definitive for the patient. It will not be possible to go back to a solution where the lead is free, and all the risks we're mentioning may occur. So a jailed lead is something that we would like to avoid, but sometimes it will occur, and this is why the discussion is so important.
That's very interesting. Thank you so much for raising these points. How is the future is going to look with the leadless pacemakers? And is there a tendency to preserve the tissue, the tricuspid valve, by using more leadless pacemakers?
Well, it's very important because you know that we are using the leadless technique since, let's say, a couple of years, and we were using leads for many years before. So this is a new technique, but this new technique has many advantages and many potential advantages. And one of the advantages is that we preserve the tricuspid valve, meaning that we don't cross the tricuspid valve with a lead, obviously, because there is no lead. And there have been some studies. We performed a small study in my center showing that there is no major interaction between the device and the tricuspid valve apparatus. I mean, even if the device is not so small and is in the right ventricle, it doesn't really interfere with the tricuspid valve apparatus. So we believe that implanting a leadless pacemaker is a very good solution for a patient where we want, in whom we want to preserve the tricuspid valve integrity. So this is an important aspect. But we have to keep in mind that for the time being, leadless pacemakers do not really cover all the indications for cardiac pacing. I mean, a leadless pacemaker cannot pace the region of the left bundle branch, which is a region we want to pace for giving a more physiologic ventricular pacing. Also, leadless pacing in case of resynchronization is something which is very difficult up to now. There are very few devices allowing for a leadless resynchronization. So I would say that this is for sure the good solution if you want to preserve the tricuspid valve, but for the time being, we do not have a solution for all patients, and we still have some patients in whom we will have to cross the tricuspid valve.
Thank you so much, Jean-Claude. Last question. As a world lead in electrophysiology, what do you think that will be the next hot topic in research? I hear a lot about different types of pacing, or do you think there will be new devices?
Yes, for sure, there will be new devices. I was telling immediately before that we don't have leadless pacemakers for pacing the left bundle branch area. And this is not completely true, because during the ERA meeting, which was last week in Vienna, we had some presentations of very initial experience about pacing with a leadless pacemaker, the area of the left bundle branch, which is very important. So I think that really we should keep working in this direction, doing as much as possible without leads. So it means that we have to improve our technique for physiologic pacing without using leads. And this is something that we discuss in the document. The other aspect is that, but this is really something about research in cardiac pacing. We do not know exactly what should be the exact position of the leadless of the left bundle branch area pacing as compared to the conventional biventricular pacing. This has to be improved. We have to work a lot on this to really know in which patient we have to use the one technique and not the other one. And lastly, I would like to tell that regarding the paper we are discussing today, we mentioned it. It would be very important in the near future to get scientific data about the exact role of jailing a lead, for example, because of course we will have many cases in the literature, and we should really collect all these cases and really see what occurs to these kind of patients. And also, we have to collect data about the transcatheter tricuspid valve interventions in patients who do require a pacemaker, who already have a pacemaker or an ICD, and also what occurs in patients who do not have pacemakers and ICDs, in order to see if the intervention has some detrimental effect on the conduction. This is something important. So keeping an eye on this kind of data that we really need for improving our practice in these patients.
Thank you so much. That was a very interesting discussion. I learned a lot from you. And of course, I prompt everybody to read your document. I think something very unique as well is that it's applicable for everybody. Either you are electrophysiologist, imager, interventionalist, surgeon. I think everybody should read this document. So thank you so much once again. And thank you all for attending this Euro